It is my pleasure to be able to welcome everyone to Global Health Week. I'm Aisha Yousafzai, for those that don't know me, and this year Global Health Week is marking the 30th anniversary of the 1994 International Conference on Population and Development, which placed sexual and reproductive health rights at the very center of the Sustainable Development Agenda. So we have a number of key events lined up over the week, starting with the incredibly fantastic debate with our team of 4 here. And then tomorrow we have a virtual conversation between Carmen LaRosso and Kelly Blanchard on sexual and reproductive health. Wednesday, we have a screening of the documentary The Janes, and Jacqueline Barber will be leading a conversation around that. And then on Friday, we have the Global Health Week Symposium and Poster Day, which I know many of you will be participating in. And this will also include a keynote speech from the United Nations Population Fund's Natalia Kenner. So please try to go to as many of these events as possible. Before I hand over to Nikki on the faculty debate, I just want to remind everyone that each of the speakers is representing their own perspectives and their own views, and they don't speak for the department or for Harvard as an institution. So with that, I'm going to hand over to Nikki.
Once again, thank you so much for coming today. Just to intro today's event. We'll be having a fun little debate about the role of high quality evidence about what works and what is the most important in the gap in maternal health policy making. A bit of a long title. Today's debate will be between Professor Margaret McConnell, Professor Kevin Croke. Margaret McConnell is a behavioral economist here in the department, primarily working in maternal health care and maternal care in LMICs. Similarly, Kevin Croke is a political scientist, also working in a similar field.
And today, during the debate, we'll start with opening statements from both sides and then move on to arguments and rebuttals. And then we want to involve everyone who's here and everyone who's on Zoom, and welcome everyone to kind of share their sides, share their opinions, and then we'll come back together and they'll incorporate everything that you all have said into another rebuttal and argument, and then they'll leave and we'll vote on which side everyone thinks won. You'll have to pick a side.
But no, with intros, right? Sorry, minutes.
Yes. Okay. Thank you so much, everyone, for coming. I'll start out by saying I don't see myself as an expert on maternal health. I'm not a clinician or obstetrician or maternal health epidemiologist, but I do work on health system evaluations, which sometimes have maternal and newborn health as an outcome. So kind of from that health system perspective that I'll speak today. So the question about whether evidence is the key gap, I think to start out, I'm going to take the big picture approach from sort of 10,000 feet. And I'll just say, when we think about whether or not evidence is the main gap, we have to first start out by frankly acknowledging that what we're currently doing is not working. Maternal mortality was declining at a pace of roughly 34% over a 15-year period, over the MDG period. Since that period, the decline has essentially stalled. So from 2016 to 2020, there was minimal reduction, and that was before COVID. And so what we're doing, what the global community is doing is currently not working. If what you're not doing is not working, you need to rethink and come up with new programs, new ideas, new interventions. And a logical place, a very important place to look for that is from research. And so so that's why it's a key and maybe the critical missing piece.
Welcome. I would just like to start by saying we appreciate you being here. We look forward to you choosing a side, one side. I'm going to start with the perspective that when we come to the sort of most important gaps for making policy better, of course, no one would deny that high quality evidence is valuable, but is it the most important thing to close that gap? I'm going to argue that it may not be, and that evidence is not always enough. I think Of course, as someone who dedicates her life to the generation of evidence, this is maybe a bit depressing, but we all have to be realists. When it comes to people who do sort of trials and evaluations of policies, I think sometimes we imagine that if we undergo an evaluation of a policy, if we find that it works, it should automatically sort of scale up, proliferate, and be implementable everywhere in exactly the same way as it was when we demonstrated that it worked. If we find out that something doesn't work, and it's a widely, loved political program, we imagine that somehow the knowledge that that program doesn't work will sort of mean that we no longer pursue that program and pursue other programs that do in fact work. And so this is the sort of thinking, I think, that underlies a lot of evaluation that I would argue misses a lot of the challenges with actually, learning, with implementation, with the delivery of programs, with the politics surrounding programs, and I'll get into that more in my arguments about why evidence alone is not enough.
All right, so my colleague has put me in a difficult position. As a political scientist, I'm accustomed to arguing that ultimately it's all about politics. Of course, politics is very important. You should take GHP 212 if you want to explore that in more detail. But I would argue that this is a unique issue space in which evidence is especially neglected. There's a couple of technical reasons. So maternal mortality, although not rare enough, is a relatively rare event in a statistical sense. It means we have very poor data on this in many low-income countries. Countries that do not have complete vital registration, we really struggle to even develop strong epidemiological or observational designs to study maternal mortality as an outcome, not to mention intervention studies. So we have just very little. We've underinvested, I would say, in research on this topic because it's hard, even though it's incredibly important. Second, it's a systems issue. And as you all know, in global health, we have many vertical programs and disease focused programs. Those things get relatively well researched. Systems issues get neglected, and maternal health being a systems issue is neglected in that way. Now, is it the case that policymakers are waiting for our results and will immediately change policy based on new results? I would agree completely that that's not the right model. But scholars of evidence to policy have sort of said there's a kind of direct policy translation model. That's the model, and I would agree. We often sort of bang our heads up against the wall when we expect our results to be taken up into policy in that way. What I would argue is a kind of maybe less direct but very productive way of thinking about it is that research really helps create an ecosystem in which policy concerns on specific issues are taken seriously. They rise to the top of the policy agenda when they're carefully measured, and especially when researchers can build partnerships with policymakers over time. If researchers are embedded in institutions and can develop relationships of trust with policymakers, in those cases, research results can be taken into policy in a maybe a less direct way, but I think in possibly a more sustainable way. And yet this hasn't happened in many cases in the field of maternal mortality, partly for the reasons that I mentioned before, the data issues and the neglect issues. And that's why we need to, I think, rededicate ourselves to new interventions, new thinking, and higher quality research on this topic, which could then help mobilize political will to tackle these critical issues. Thank you.
Thank you. So I'm going to go with my 1 minute rebuttal. I think Kevin makes a number of good points, in particular about the dearth of evidence. I think the sort of key point of this debate is whether evidence about what works is the missing ingredient for closing the policy gap. And I think sort of, I also appreciate the sort of research policymaker collaboration suggestion. From my experience, one of the biggest challenges, the biggest enablers of the use of evidence is a policymaker who's a champion, but that also means that policymaker who's a champion will move on. And that relationship, sort of, for all the success of developing those partnerships, they are as fragile as the, policymaker sort of who tends to stay in that job 2 to 3 years. And so I think that's sort of one thing to think about. And I'll leave it there for my rebuttal.
1 minute is tough. I would say Wait, what happened?
It's time for our argument.
Oh, she argues and I rebut. Perfect, okay. That's good, because I didn't have a good rebuttal.
So I wanted to sort of start with, what I will say is that I guess, the reason that I, ended up on this side, though Kevin and I largely agree, is I did just spend 4 years, enrolling for a trial, 6 years following up on outcomes in that trial. The trial involved the sort of evaluation of an expensive maternal and visiting program that the research itself involved collaboration with Medicaid and other government partners. So if you think about the sort of ingredients for evidence to policy pipeline, the sort of evidence was embedded within an actual policymaker institution, the outcomes that we cared about in the population that we cared about. The trial itself was rigorous, incredible amounts of energy and effort went into it, a lot of sort of transparency and buy-in. And what we learned was that program wasn't as effective as the policymakers hoped on the outcomes that they cared about. And, what I saw at the end of that trial was sort of, I think has made me think more about what we do with evidence and how you think about what a policymaker needs to know when you're generating evidence. This program is politically popular and politically desirable and for that reason has many defenders. And so, may go on sort of forever. The impetus to learn, well, what else could we do to move, preterm birth, maternal mortality, other outcomes that we care about, that's much more challenging. We are starting from a base of not knowing very much. So knowing that this program didn't work to move those outcomes wasn't enough to get us toward programs that do. This is not my experience is not unique. I went back and I looked at, there are nudge units, which are behavioral science units embedded within governments. And so again, this is a best case scenario. We're doing randomized, rigorous work. It's done by a government partner. It's embedded in actual government decisions in sort of policymakers are helping to design the trials, care about the results. There's a meta-analysis of those nudge unit experiments. I want you to guess what percentage of the successful experiments that have a positive treatment effect that is statistically significant are actually adopted by those governments. Raise your hand if you think it's 80%. Raise your hand if you think it's 50%, 40%. It's 30%. And this is the best case scenario. So I think, of course I will continue to test what works, but I think we need more people like Kevin to understand, why things aren't working and what some of the barriers are to actually getting to better outcomes. I'll leave it there.
Very fair points. I will flip that though and say, wow, 30% of those evaluations got taken up and taken into policy. My prior would have been much, much, much lower. And that sounds like a success story, to be honest. So I think, it sort of depends on what we think the base case is for the policy translation process. If we start with the assumption that politics is not about policy, politics is about interests and coalitions, and evidence is a completely, epiphenomenal, logical irrelevance, then 30% sounds amazing. And honestly, I think we should be encouraged by that. Secondly, I would just say your experience, it's amazing the way you describe it, embedded in government and working over time. And it may be, I think, frustrating that it hasn't yet borne fruit, but I suspect it will. And also, I think, one thing that I sometimes think about is individual papers don't change minds, but sometimes literatures and accumulation over time. Sometimes people need time to change their mind, to admit that the things they've invested in, may not be effective. And so I suspect, the work that you've done will actually change minds over time, and not just among researchers, but also in government, or at least I hope it will.
Okay.
Great, so now we're gonna move to the section where you all choose sides and we'll confer. And you all can talk about if there's anything that they left out that you think that they should argue for or against. We could do like half the room, half the room.
Yeah. So if you want to choose the side against evidence, over here. If you want for high quality evidence, which we all love, go over there. So
David, yeah.
Yeah.
If you're in the middle, know what to do, or.
I don't agree with that either side.
then pick at random, David.
So David, then at the end, you can argue with both.
So choose a side which you think you can enhance with discussion.
And we have what, 10
10
minutes?
We have 10 minutes.
10 minutes,
And we're
then we
gonna,
can-
you know, we're gonna incorporate your ideas into the next phase.
And do we get to ask questions?
There'll be some open discussion.
Yeah, I think
at
we're
the
gonna have
end.
open discussion at the end, yeah. So we're gonna do this, then we're gonna do one more round of rebuttal, pro con, and then questions.
Which side was which?
This is evidence, that side is nihilism.
This is my side. Silence over here.
Politics,
Better way. It's not that I'm against evidence.
I know, nor am I,
Like,
to be
I would
clear.
say our side is evidence
Right.
and.
And, there you go. Or evidence is not enough alone.
Correct, yeah, it's evidence plus.
That's
Plus,
great.
good. But it would be naive to
Make
think
it
that.
the next
No.
round.
Correct.
Missing.
I like it.
100%.
That's-
Yes. it's
No, I was joking.
And it was reality.
And is the biggest gap is the quality evidence,
One guy.
and what she suggested to give is not, but
What
then
is it
what
that we should
is.
be doing? What is the thing we should be doing?
I don't know, David. I think.
But actually.
But right, you need evidence about.
We should ask. Let's ask, what, if it's not evidence, what is?
Well, I actually don't know what you.
In that particular case of my study on.
No, in
political
general.
process.
Have an answer for how it makes the cycle of maternal health.
Presentation,
You have
there was a much
One line
more-
answer.
it's also evidence.
No, I think that's.
I think we need evidence, we need evidence and.
One,
Yeah.
if you think you wanna
My experience is the.
generate a little well, that's something you can study. And then secondly,
Yes. I agree.
if you think, I think this was kind of implicit in part of what Megan was saying, that
Well, I can, I
study is not
think is
just
that, you
like
know,
the treatment effect, but
what I'm doing in my work now is
process by
I'm
which you
thinking
get
about.
to that.
In
And you're
my,
saying
in
you've
my
studied
years,
that
I'm
since
thinking
birth,
about
yeah.
how hard it is.
That's what we guys.
I'm starting maternal and child health today, not that you don't have a lot of people. So that's the problem that I'm thinking a lot about. I'm thinking about the space of feasible interventions. I'm thinking, but then I'm thinking about what kinds of evidence would be useful. And then I'm thinking about what it would take for a policymaker to use that evidence to change their mind. And I'm figuring out how you could line all of those things up together. Yeah.
I think there's another step to do that
Yeah.
is like, how we should interpret that,
Yes.
right? So it's not only like, we have an RCD, but it's like,
Right.
what I compare it
the
with,
same in the
that,
future.
that is like, that's.
Is the RCT setting sort of comparable enough
One
with
of the
my
major
context where I'm making decisions?
Policy.
Yeah, or like, this is evidence of something, and there's a bunch of this history, and it's like,
One of the
what
biggest
can I do
reasons
with
that
that?
we are not.
So I think one other question is like, also not the case evidence,
They
of
know
course,
what
on that side.
We
But
didn't
like,
know.
how much we should push for that evidence. So who should do that
Research
step
is
of like
something
pushing
that
for
needs
the
to be
policymaker
adapted
to
with
interpret the
time.
evidence
It's not like,
correctly?
once I
Yeah.
have.
And like,
evidence,
right, you need to
I can
convince
It's a
policymaker how
continuous
to
process to make the
interpret all the
refinement in the
evidence together,
process.
not just about that specific
I know.
program, it's that specific program, right there.
It would get a laugh, and I will.
I'm sure that.
No, I think that's a great point, right? The urgency changes the structural context, yeah.
Also not necessarily the
Not,
case.
not necessarily the case, but
And also.
even with that
for-
assumption in
for
hand, you have to understand that constituency has other priorities other than maternal health. Now,
Absolutely.
Like
no
the
one's gonna
inequal-
say that they
maybe
don't
what
think
worked
that
at a
maternal health
larger
is
scale,
important.
maybe now we.
But
need to
if it's
shift the
not the
focus
issue in which the constituency is voting
more
on,
vulnerable.
Yep.
then
Also,
does
like,
it
when you
accurately
make
reflect the
change to
priorities of
certain
the
level,
constituency and
Getting,
of
reaching the last mile is always difficult because.
Particularly
what
if
works
the
to
most
make a
effective
bigger impact
interventions
will
would
not
take up a
work
significant
towards the
share of the
end,
budget,
so we
which
need
makes sense.
something.
Yeah, I don't know if someone has said this, but I
Ah.
sometimes there's an issue of political motivation or religion.
Yes.
So you can produce thousands of articles on maternal
Yep.
mortality disparities, et cetera, et cetera. But also there are larger political forces and social forces which shape why these health outcomes exist. And unless you tackle those social issues from a political level, like any evidence, it doesn't matter.
That may be a different
Yes,
kind
but
of
what should we do about
evidence,
that?
right? Maybe politicians are
I think
interested
our
in the
emphasis should
outcome
be
and
on
we need to show that
influencing
those
political
outcomes
motivation
are also
for social
being affected.
movements through mobilizing support maybe from
Maybe we need to think
policy
differently.
makers,
Yeah.
rather than just
Outcomes
producing
would be
paper after
interesting
paper
for
on this disparity or
can
this
help you
problem.
and how to
I think the
present.
social media suggestion is
Yeah,
one idea.
I
I've also been thinking about like, what do we know about like you know, if we think
So
that
sort of
policymakers have constraints, like
Expanding
I
the set of
don't
outcomes that we
believe
care
in the
about.
welfare state, I think we shouldn't give money
More
away to people
targeted,
because I
more
don't
communication types
think
of
that my, like, population doesn't
What
deserve it. Are
interest.
there other, can we work within the political constraints and logic?
And
of
so I
people
think
to
you're
make
saying that
decisions? Could you design an intervention
Just the
that
fact
you
of
can
having
imagine being
evidence
political?
about
One approach is like change
feasible,
what's politically
effective
possible.
policies could help
Other approach is
generate.
understand what is politically possible and impossible.
I mean, there's this
but
literature
design an
on
intervention within those constraints.
expert
Both are-
communities. One thing that sort of determines whether or not
Also about high
politicians listen to
quality.
them.
Yes,
whether or not
it is.
they
Yes,
are
great.
themselves cohesive
Yes.
and agreed on strategies, and I think if you have strong evidence, and they tend to be less cohesive when the evidence base is weak.
Yes.
Then everyone sort of has their pet theory and there's no real way to adjudicate.
Reality and people, the people who are responsible for making decisions to invest in
It's gonna be hard to fit
generation of that high
agreements.
quality
Yeah.
evidence on
Yes.
by the time those outcomes
Yeah.
come into place, and so I feel like there's also a trade-off of like, let's generate the minimums that we can at this stage to then sort of build the case that can evidence-based, cut across, or like to take one step in strengthening the workforce, for instance,
Yeah.
so then take one more step in actually getting to the point where you have enough to then say we can do a high quality study that we can take years and years and years of money.
Yeah, I mean, I think sort of.
Because
That's
they,
true, as
because
long
the
as
NGOs need it
sort
as
of
a condition of their
active
funding
community.
or,
Yeah.
yeah, yeah.
But I think there is a sort of faster,
We-
still
Let me
still
try
rigorous,
to argue that.
but it's more descriptive evidence is useful.
Um,
Fits into what people
I think
need
like
to know that's
one
not
typical way you get
low
pushback,
quality because it's
people will say,
already.
why are we arguing about what works? We know how to treat infection, we know how to treat postpartum hemorrhage, we know both what works. So why don't we just get on with it? It sort of links to what you were saying, we
Yeah.
both were saying, which is that the fact is that the way health systems are organized in most countries, people don't have access to this key clinical interventions. And so getting from a kind of theoretical intervention of high efficacy to high population coverage, there's a million strategies.
But which kinds of things,
Right, is it about the supply side, is it about the demand side, is it about quality of care versus access? And there, I think, you still find yourself, if you're
that you
I
need
would
to
also
also think
consider
about how do you
tried
sort
to say, what is the one thing I should do so that
those who
every
distribute
woman who
products?
needs a C-section can get it if they have a
Part of
lifetime
that too is
complication?
how they're being
I
adopted.
think it's really
So you know, how
That's the
sustainable is the
the most
funding,
effective,
how well is
lever
it
you
being
would
scaled
push
up,
on.
and even if you're putting in the policies, it actually being
that's
put
somewhere where.
practice. You know,
But right, okay, so maybe you are
Something
running
kind
into
of
policies
say
as
that.
how it should be, but you're not putting much attention to practice.
Sustainability is the big one, is are they actually
Yeah.
putting things in place to make sure that this is going to have a lasting effect?
To Nazia's point, it's changing.
Yes.
Like if you take a historical lens, we're not all asking the same, we should not be the same.
Yes.
It would be like
Yes,
some
some
like resource constrained
Yep.
settings, it's
Yep.
like
Something in that.
you're investing so much for something that they will
But
also
what the
use, like,
next
help
generation.
maybe not.
Or may not, but and when we
Or if
often,
it doesn't.
when we often lack
Yeah.
facts about base reality, like
Yeah.
descriptive, sort of decision relevant facts about
So,
base reality.
sorry, you're gonna-
What's that? Okay, yes.
So I'm gonna be GYN and I have one example. So
Great.
the Gates Foundation funded the MOTO trial, which is the TXA for postpartum hemorrhage reduced deaths.
Yes.
I think there are,
So I went
do
to
you think
the
those are
in
not
January,
well described by
and why
current research
use
or not?
TXA, great in theory, but in reality, they don't have TXA. So he said 90% of the time their hospitals do not have TXA, it's funded by the Ministry of Health, they don't have it. So there's this big disconnect between theoretical.
That's a good argument.
Yeah,
We always need
Funding.
more.
And one of the midwives keeps the stash of it in her purse, like a personal supply that she uses. when
When
she
you
thinks
talk
she can
about
use it.
evidence, it's
And
about
actually saves
single
someone's life.
And she knows that she has it and she.
Yes, she showed it to me in her
Yeah.
purse because she said
Support
90%
each other.
of the time we don't have it, so I just keep this. So I actually can, like the week we were there, two
Not
women
very
died. of
confident, like
They had
when
no
we
blood,
bundle
no TXA.
interventions together.
But the Gates
how
Foundation
does that-
would put millions of dollars.
If we want to change, when really
The
that
research
big
says
shift
that
of
there's no
outcome,
plans there.
we need bundled interventions. and
Correct.
We need to
It
know
was
that.
incredibly
What should
frustrating.
be the bundle? What goes into the bundle?
Yes.
That's true.
What's your name?
and we can,
Um,
and
It's
the argument that we
yeah.
currently lack
I think this is-
information on these.
Yeah, I think we do not have much.
I mean, to be fair, I
We
think
don't
we
know
can
how to
also study
best
what works
integrate
in changing the
how to
conditions.
best
that lead to
integrate it.
why and the.
We don't
That's,
know
I'm
best
arguing
like
against ourselves.
what the best bundle is.
Do we
know
have time
what
for one, does anyone
individual
else wanna add
ingredient
something?
is, but we do
And
not
thinking
know
about
what the bundle is.
Yes.
Quality evidence, which takes long time, like I
Yeah.
don't think if you have to make trade-offs between high quality evidence and then.
Which we know we had there was a level, we were still struggling. And right now, I'm dying, going through the entire logic model, trying to know why it didn't work. And try to find another one that actually work in the next ICT, for example, but it's hard. So I totally agree with you.
Your testimony as well.
So fine to sort of pursue these long.
We're back.
But we also have to, I
Okay.
mean, I think.
So,
you know,
What I got is
we
the
have to
main
look
key
at
points,
our
the importance of
time,
studying
the answer
implementation,
is-
the importance of change over time, the
May not
the fact
be
that
like
we study the policy
very
making process
scientific and viable, like.
process just as systematically as we study
We do already know many things.
side of things and also the kind of implementation, kind of getting inside the black box of implementation, or you could think about it as there's kind of
Descriptive,
implementation
there's like
in
in
the
it.
big picture sense, and then there's kind of
Descriptively.
within bundles
Or
of
is it- there's no
intervention
yes,
packages might be used.
so you can't get, like, there's no. kind. That's not evidence. But that is.
Noted.
Sort of the kind of descriptive data and information.
All right, thanks, guys.
It's not free.
I'm just gonna jump right into round two. I wanna use some of my 3 minutes to say that I appreciate the really excellent discussion we had on my side of the room. Where we changed our position a little bit from nihilism to evidence and, or evidence plus. So I think one of the main things we talked about was the sort of incredible amount of time and expense involved with generating really high quality rigorous evidence on what works. And, you know, a focus on sort of what can we do in the short term. You know, we know a lot of things, we have a lot of evidence about the kind of interventions that can work that we're not currently using. You know, can we sort of do a better job generating descriptive data and learning about what is the base reality for maternal and child health, and where are the interventions that we know, you know, resuscitation. There's some basic maternal and child health interventions that we know are working that are not currently happening, that we could be doing a better job of understanding and holding policymakers accountable for in terms of descriptive data and reality. I think the other sort of excellent point that was made by you know, Kathy, who just recently had the experience of sort of an incredibly effective intervention, which is sort of TXA for sort of hemorrhage and you know, the sort of on the ground reality is TXA can be very, very effective as an intervention, but if none of the health facilities have it in stock, then it's not going to be effective. And so some of that is how do we sort of understand why that is? We can't solve that problem unless we understand why that's happening. What are the main reasons that is it stockouts? Is it sort of other challenges? Before we understand why, any intervention that we even think about is not going to be effective. And so the incredible focus on what works often means that we're not understanding why it is that something basic, like why are we not resuscitating babies? Why are we not taking blood pressure postpartum? Even though we know, of course, that these things are the key core components of maternal health. I think the other sort of important element that we brought up is sometimes politicians don't have the will or the interest in doing things that work. And so some of our energy has to be spent on changing that either by sort of altering, you know, politicians and what they think about, or considering interventions that are politically feasible and politically desirable and testing within the space of those interventions. And that this should be sort of part of how we think about generating evidence in what works. I think the other thing is sort of how do you analyze, interpret, and help policymakers prioritize, there is a lot of evidence about what works. A lot of us sort of get to the point of generating high quality evidence, but it's hard to use high quality evidence for decision making. And so support to decision support to sort of policymakers, the kinds of things that CS is doing, sort of like how do you translate everything about what we know to what are you going to do about it is as important as knowing what works. So I think that's all.
I think that's a great summary, and I think given the way you've presented your position, there's a lot to agree with. But I would just sort of zero in on one of the things you said, which is that we have so much intervention, so much knowledge about interventions that work, and therefore we just need to go implement them. And I think like that's actually the crux of it, right? Nobody, and this goes way beyond maternal health to so many things in global health and in global development more broadly. We have specific clinical interventions that we know in a controlled setting have high efficacy, but how do we get from that to intervention at scale? That is itself the most important area for research, I would say, and the most important knowledge gap. And so rather than say we actually don't need more research because we know these work in controlled settings, I would say it's precisely the sort of adoption and scaling process that is an important gap for research. Great. So I'll just reflect now, kind of moving away from the specifics to highlighting some of the excellent comments by our group, Team Evidence, and some of the things that they came up with really overlap with the points we've made, but they've brought other points into the discussion. And one point which came out very clearly is that I think both implicit and explicit in what Maggie's been saying is the idea that really the missing ingredient may not be evidence, it may be some kind of broader political will. And I agree that's critical. I would also agree, as my group has highlighted, that this itself can be studied systematically. And so one of the things, there's a large literature on kind of how policies get on the agenda. And if we think that's what's missing, we should try to understand this process much more in a much more detailed way. One of the things that literature tells us is that both measurement, which is a research function, and also the availability of effective and feasible interventions are one of the things that can themselves help generate political will to do something about a neglected problem. So that's one point. A second point is that my colleagues have pointed out that a lot of what we really need in, especially low-income settings, to understand better is to get inside the black box of implementation and to study how programs are implemented. We can also do this scientifically. We don't have to just study efficacy. We can also study implementation at scale. We can try to unbundle different components of programs. We can also try to recognize the fact that although we have a reasonable amount of descriptive epidemiology of maternal health, the burden of disease changes over time. And so we shouldn't assume that the kind of either the social determinants or the health determinants that we've identified in the past are going to be those that continue into the future. And we should also recognize that the requirements of reaching the last mile and achieving equity will be different than the kind of initial low-hanging fruit, so to speak. The last point I'll make is just a reflection on my own work in recent years, working on a maternal health and newborn health reform in Western Kenya. This grows out of work that associated with our colleague, Professor Croke, and many others around the Lancet Global Health Commission around an intervention called service delivery reform for maternal and newborn health. And this is something that I think, in 30 seconds, I won't be able to describe in detail, but I will say it's something that has been, I think, a compelling vision for many policymakers. But one of the things that has held back broader adaptation is that there are no rigorous prospective studies of the intervention to date. And so I think it's a very clear example of something that is being held back by an evidence gap. It's a gap we're trying to fill. But it is something where if there was convincing high quality evidence, I think the implementation, funding, broader momentum, political will would move much more quickly. And with that, I think I'm out of time.
Wonderful. So I think you know, I feel that sort of, it sounds like your group has come around to our position. That what we need is not more evidence about what works, but more evidence about, you know, the conditions under which interventions can work, the sort of, you know, political determinants that support effective interventions, the sort of understanding why, you know, certain policies are, you know, being adopted or not adopted. So with that agreement in mind, I'll leave it there. Now closing statement.
Oh, closing, okay.
Actually, that might have been the closing statement, so maybe we should, since we have like, you know, 15 minutes, maybe we should open it up. Or should we, or do you wanna close?
I think we have to go out of.
Oh, right.
This is like a dissertation defense. We have to leave the room. You all vote. We should have done this as a difference in difference. Should have voted.
Ooh, yeah.
Oh.
A missed opportunity for high quality evidence.
Yeah.
So the two sides are, and Gioni and Nikki, we were gonna do closing statements, but I think we concluded fairly well. Gioni and Nikki are gonna collect the votes by hand raising when Kevin and I have left the room. So you can feel free to be as ruthless as you want to be. The two sides are pro evidence and evidence plus. Or evidence and.
We may have
And
changed
then
the
we'll have an open
goalpost.
discussion.
Matters to the room when you see the window.
Go around the corner.
Oh,
They're gone, they're gone.
Little scroll. Alright, please go ahead. More slides.
Yeah.
Alright. Y'all ready?
Who's
So what?
anti-evidence?
Oh, hey now. It's pro evidence plus. Who's pro, like, who's voting for Maggie? Oh. Hey, hey. Alright, no, keep your hands up. I don't need to go on count. Alright, we got 15. And who's for the losing side?
No, I mean, you need to correct the statement.
Who's on Kevin's side?
And Aisha counted also.
Yeah, that's fine.
So we got here, so we got 1, 2, 3. 9. Is there any abstains?
Oh, and then somebody on.
Boston.
Okay.
We're good, 10 to 11. No neutrals? Nice. Alright, I'm gonna go, oh, they're going back.
Are you done?
Yes.
Okay, before,
Oh, sorry, wait, but who's voting for?
No, no.
The people on Zoom. Yeah, ask them to vote.
Oh.
Nikki, you have to count the Zoom participants, no, our votes.
You guys are behind me, we want, okay.
I'm voting for Kevin. I'm voting for Kevin.
Okay. And Kevin.
Yes.
Exactly. And Thomas.
Me too. I'm voting for Kevin too.
Yes. 13, getting there.
Closer than.
Alright, I give you got 5 seconds. I'll just do more minutes. Maybe
No,
more.
the chat was.
Alright. I'm closing the vote. We're done here.
Thanks for your participation.
Well,
okay, before we reveal the votes, I just wanted to say,
oh my goodness. I mean, they know it.
Kevin and I largely agree with each other, which is why we had to exaggerate our positions a bit so that we could enjoy this debate and have something to debate about.
I don't think Maggie's really team nihilist, for example.
Although I deeply care about high quality evidence. So I thought I would take a challenge today.
Same. And I do believe that political factors are important. It would be weird if I as a political scientist in the department did not feel that politics plays a significant role. But, you know, I think it's actually a healthy thing to you know, take the other perspective. So I hope it's been informative and I hope I won. But based on what I see in the
Wait,
chat,
Tom
I
has his
might
hand
not
up.
have. Oh.
No, that's from
No,
the
no,
previous
that's-
vote. Never give me.
No, keep put it this.
Don't
You
know.
just put it back. We already counted.
Yeah, I did.
Oh, but maybe he has a comment.
Tom, do you have a comment or do you,
I can hold my comment until after you.
okay,
Alright,
alright, go ahead.
3,
Yeah.
2, 1. Maggie won. It was tight.
Very
It was,
close.
okay,
15-13.
15-13.
Well, we didn't.
That's a non-statistically significant.
precise.
That's a rough variance.
All right. That's right. Who knows? Great job, Maggie.
Great job, everybody. Thank you all for your many contributions. I really think the refinement in messaging from my team here was extremely helpful. And now it's just open it up to like discussion. Let's start with Tom. Tom,
Yeah.
go for it.
Okay, yeah, and I want to say I really enjoyed listening to you guys, and I'm sure that we all agreed more than you were able to make the differences. And I think there were 2 points that Kevin made that I think were particularly important for those of us who work on the politics side. And that is, just because your evidence doesn't turn into political decisions doesn't mean that it couldn't in the future. And that 30% was a pretty good rate, because it's very difficult to change policies. And the second thing is the idea of how things may need to come together in putting stuff on the agenda and to get things ratified even before they're going to be implemented is part of that process. And one of the key things that at least Kingdon, who talks about is how technical people come together and agree on a policy as part of that process. And so if the technical people are concerned about high quality information, then that would be part of what you would want to do. Make sure that there's consensus among the technical people that this policy would be better than the general policies that could be failures, right? So that I think that's another element. But it also occurred to me that maybe lousy information is good.
That's what David said.
Yeah, so
Oh, did they, okay, because I think first, currently, the power of misinformation is quite great, right? So you may want to think about this. And I had the kind of strange experience of meeting someone who had been part of preparing the evidence for the early family planning policies, which were called population control policies. And I asked him, where did they get the data that they used to convince people that population was growing so fast that they needed to do something about it? And he said to me, we made it up.
Wow.
So the origin of a lot of the issues that your panel discussions this week are about came out of bad information. And so I think it's up to, well, maybe David has a better sense of what this is about. But I think that's, that suggests to us that that's another element, not maybe among the technicians and maybe the people who know the methodologies and how to do this, but it's another element of thinking about how do you try to convince people to do the right thing.
David has a follow-up on that.
yeah, I was just, I was actually going to argue for low quality evidence. You're arguing for high quality. And my experience is the high quality evidence tends to be very specific and small scale. And the low quality, but a lot of the issues are big. And so I'll just give 2 examples. One is my own work on the value of vaccination for economic growth, the impact of child vaccination on child health, schooling, worker productivity. We had estimates of that, which I think were very low quality because it's a very long-term effect, and we're using aggregate data, but that had a lot of impact on funding for vaccination programs for Gavi. But I think it was low quality. And I'd also point to Chris Murray's work on the global burden of disease. They have estimates of every disease in every country, which is based on very little raw data. It's modeling exercise.
But just
And I think that has been very
that has been very impactful, but that doesn't mean that it's, I mean, I guess what I would say is like, I would, in terms of what works, I would take really high quality, expensive, well-done study over 100 poorly powered, poorly done studies. In terms of like the impact on, like in terms of political influence, I agree with you. But in terms of like the potential impact on health outcomes, I feel like we might need slightly less evidence. Less evidence,
Fewer but better. but-
fewer studies, but better studies.
But David, so that presumes you already know vaccines are good, which
Yeah.
I think we agree. But so that may be a special case where you say, we know vaccines are good, we need to mobilize
Right.
funding for it, therefore this other kind of descriptive, cross-sectional, whatever is okay. But I mean, that may be okay in these subset of issues where you're very convinced, but you're convinced on prior high quality evidence, right?
No. There's high quality evidence that vaccines save children's lives.
That's what I mean, yeah.
But the evidence that it has a morbidity effect on cognitive development and education, and that in the long term, worker productivity goes up because of vaccination, we have very little evidence from.
Yes.
You need very, large, long run
Yeah, yeah.
randomized trials following up children for 30, 40 years. We don't have that. There was, I think, suggestive evidence, which I think is right, from macro data that healthy populations tend to be more productive. But I would say, to me, that's low quality evidence, but it's very impactful. And I think, again, the Chris Murray evidence is probably the best we have about burden of disease. But it's not very high quality. But policymakers want numbers, they want to know.
Prioritizing.
And saying we don't know means that you don't really get a word in the debate. So doing the best you can with the evidence base that you have, I think is important.
But I wonder how we can sort of change the dialogue a bit to be more honest about places where we don't know. Because I think one of the ways we get in a lot of trouble is by looking for, like, we need an answer, we're gonna spend this money, we'll take any modeling to make incredible decisions with enormous amounts of money where we basically have no information. Like, I think we have to allow more sort of humility about how many places we don't know. And I mean, this is more to make Evan's point. But let's open it up to other questions or comments.
Yeah, I have one. I just quickly review a story I heard before. It's about the famous statistician R.A. Fisher. His study on the lung cancer and smoking and lung cancer, because he smokes a lot. Like sometimes he doesn't. Even though there are data, and he is a famous statistician, he's able to do high quality evidence, but from some views, he doesn't want to accept or do the evidence. So I think in addition to the evidence, people's view or social norms is also important.
Yes.
I mean, that maybe speaks to your example, Maggie, where people that were very invested in the program in South Carolina didn't want to change their minds even when presented with very high quality evidence that it wasn't. I mean, in the maternal health space, I often think about, there's a very well-known trial called the Better Birth trial, which took place in northern India or some point in the past decade, and it took an intervention that, there had been a really well done New Yorker article written by Atul Gawande, and I remember reading that article, and I remember thinking it was incredibly compelling. And I think it's the kind of intervention around coaching and adherence to a safe birth checklist that you think it should work. It's a composite of evidence-based interventions. And yet, in a given setting with a given intervention modality, it had a very, like this debate, it had a statistically insignificant result. And I think part of the value of strong evidence is that even if you're invested in the outcome, you have to reconsider it. So if you have kind of competing low quality evidence, everybody retreats to their priors. Say, well, I can poke holes in your study, you can poke holes in my study, and there's lots of confounding. Let's just go back to what we already believe.
Yeah.
But in some cases, you can construct a very strong trial which can actually make you change your mind. And that's it's very valuable.
And perhaps I took this position as a form of therapy, because I appreciate like when you said to me, maybe someday but I do think it's true that there is an incredibly long cycle for evidence, especially evidence that goes strongly against people's priors, and that's natural and would be sort of sensible. I think the sort of question is, how do you create like the bravery and space for the kind of evidence that actually is informative and does change people's beliefs, which is also very threatening and destabilizing. Because that Better Birth study was like pretty seismic in terms of sort of what it meant for the field.
And we learned a lot, I think, from doing it, and also just from a lot of rich descriptive data in that trial. I think it's hugely valuable.
Yes.
But probably discouraging if you were really invested in that intervention. comments.
Thank you. This was very insightful, and I wanted to ask both of you then what kind of advice or like what kind of mindset that we should take as researchers who's trying to generate evidence in global health.
So I've been thinking about this a lot. Again, this is part of like coming from my existential crisis. I think talking to policymakers and you know, I mean, I actually think one of the things that you don't get to do early in your career is talk to people who use use evidence, you know, think about it. I think talking to those, if with a few exceptions, one of them that I'm looking at here, you know, understanding what evidence do people need, not just like what's an interesting question, but what sort of, and I think when you're thinking about a study, sort of, this is sort of to Kevin's point, like what do we learn either way? If you're doing a study because you think you already know the answer and you just want to prove it, you're not actually learning anything. And so, you know, you want to kind of design a study where if you see one result, you think one way about the world. If you see a different result, you know, that the sort of the information itself, you want to understand why you need to know the answer to the question. And I think sometimes we answer that in a very academic way, but I think the more you kind of understand and are embedded in what the policy conversation is, the more you can generate a result that pivots that conversation in a direction that is more evidence-based. But you really have to understand the conversation that's actually happening. Like you might wish the conversation was over here, but if it's here, you want to have your study like speak to the sort of the conversation that people are actually having.
Yeah, I think that's great advice. I would just emphasize the value of trying to talk to people in government before you start the work. And I early on in my career, I felt that it was almost presumptuous to take up their time, and people probably don't want to meet with me. I'm very junior, and you know, there's some of that. But I think if you believe in your research, and you should, then it's going to be more valuable if you can make them aware of it in the beginning, but also get feedback, and also research that somebody has been informed about and has known about and has followed along for a long time is going to be something they're going to be much more invested in the outcome of than if you do a dissemination after the fact.
One other thing I would say is I think another thing you could do is read like journalism and you know, sort of broader conversations that are happening about the topic that you're interested in. It doesn't mean that that's what you should use to choose your topic, but to understand where the conversation is, it's a combination of talking to politicians. Even like the other thing that I never really understood is like a lot of the action is lobbyists, and people who sort of the people who produce and manage the evidence are the ones, and so you don't have to take on what they're doing, like, but you understand how they talk about things and sort of make what you're doing at least in conversation and orbit with that, so that it's not like a totally alternate reality to where the sort of research is.
There was another hand at one point.
I just want to make a comment. I'm an OBGYN and I practiced in California for a long time. We always talk about only doing evidence-based medicine. But then when I did go to Uganda, it was so much harder to actually do that because of a lack of supplies and essential medicines. And so I feel like that's why I was on the side of evidence and feasibility, funding, political reality. But I don't know, I'm not sure like how to make that next step. Like, how do I get the Ministry of Health to actually supply those essential medicines to the government funded hospitals?
I think the problem is our evidence base around what we know about what works to solve these kind of problems is really limited. And every time a funder goes into this space, they do something, they get really confused by it, they're kind of like, and then they retreat to like funding more technologies. But I think, I mean.
The funders that might have done that.
But I mean, this is where I like agree with Kevin that we need to think more rigorously about how do you generate evidence about how to solve these problems, because we are really like in the dark about.
Seriously, I want to go to Bill Gates and say, you know, you funded this trial, you found that your calibrated drape really helps with postpartum hemorrhage. But literally not a single person in Uganda has ever seen that drape. It's too expensive. And so like no one's using that drape there. And I don't think it's gonna happen anytime soon. Unless you want to provide funding for those drapes.
And we don't even really understand many of the whys of, you know, sort of some of the basic, you know, staffing shortage. So, yes. And I think this is sort of where I would also harken back to Kevin's point about having realistic expectations that, you know, maybe that 30% is actually impressive. And there are, you know, there are some things that might take a while. And given that we are at a sort of smaller, we have to maybe be more content with smaller wins, but we don't like those small wins and incremental learnings. We want the like, this thing is gonna like completely knock out half the hemorrhages that we see. And that feels like, oh, you know, we could do this, but yeah.
Yeah, it's a great comment. I don't have any further, other than that, I think, you know, the nuts and bolts of health systems is, I think, very, very understudied. Provider payment, supply chain, human resources. There should be more work in this area, there should be more funding in this area. It's the backbone on which all of the interventions rest, so strongly agree.
But can I come in here?
Yes, last word, Tom, you get the last word and then we gotta let people go.
Okay, I mean, it's one of the issues is about the quality of the evidence, right? And that often shapes the narrowness of the questions, right? So if you want to ask questions that are more broad about human resources or decentralization or the other things, if you're going to try to do a random trial, it's awful difficult, right? And so it seems to me that one of the things to do is to think about what is the best evidence for the kind of questions that you're interested in. And that not be driven by the more scientific evidence, because you that limits the kind of questions you can ask.
I mean, just to speak against my own self. I agree but disagree, because I think you can know very well, you can provide descriptive evidence and associations and correlations, but it doesn't tell you what will work to move the needle on something that's, you know, better. And so even descriptive evidence, I think, is highly undervalued and we need more of it. And that's probably the first way to go. But without sort of some kind of causal inference, high quality evidence generation strategy, why should I put a lot of money into health system interventions if I really don't know if they're what's moving the needle? So
my point would be that people will put money into those. People say, oh, decentralization is going to work without any evidence, right? And so it's better to say that, well, the associations or the descriptive evidence that we have seems to suggest that if you do decentralization in this particular way, it's likely to work better. And a lot of the implementation science is about that kind of thing as well. It seems to me that does, in the absence of the ability to do a more sophisticated and very expensive model of how decentralization works, it seems to me that we have to say, well, we still need to do some kind of evidence about what works better and what doesn't, or appear to do that, even if you can't scientifically attribute causality to it.
I think just looking at the clock, I think that's a appropriately nuanced and complex take to end the discussion on. So
thank you
with that,
to everyone, and especially to Joni and
thank you all for coming.